Dr. Hakim has balanced private practice and dental education for 31 years in the San Francisco Bay Area. He splits his time between real-world, wet-fingered private practice and teaching dental students at University of Pacific, as well as colleagues across the country. He earned his DDS in 1991 and went on to earn his MBA in 2000. His area of focus ranges from predictable and lasting adhesion, minimally invasive single-tooth dentistry, all the way through full mouth aesthetic rehabilitation and smile design. Thank you, Dr. Hakim. Welcome.
Thank you for the great introduction. It's great to be here. Often I'm traveling somewhere and speaking to people I've never met, making new friends. It's really nice to see a lot of old friends. There's a bunch of old friends in the room, obviously teaching for so many years at Pacific. I'm going to see a lot of graduates. I think at this point, since teaching in 91, I might have 4,000 students that have graduated underneath me. So it's really cool to see all the people that came up and giving hugs and handshakes and what have you. I think I presented to this group maybe in 2012 or 13 or so. So it took a long time, but I'm happy to be back. I have a lot of content because originally I thought I had a little bit more time. I've squeezed it up, but for me, it's not about getting through all the slides. It's always about interaction, so feel free to raise your hand, stop me. I'd rather answer questions and leave some stuff on the table. But if I'm talking fast, normally I go slow. It's because I'm trying to get through some of the content for you guys. So you see the topic, the group. Can you guys see it in the back, or is it too much light back there? You know, this is one of the older topics. You guys are good? This is one of the older topics on my kind of menu, but the group chose it. And really, at the end of the day, what we're talking about is how a lot of the metal-based crown and bridge dentistry has gone out of favor, and now we're dealing with modern ceramics. So we'll talk a little bit about everything crown and bridge. This is often a one-day, if not a full two-day course if there's a hands-on component. So we're going to give snippets of it in an hour and a half. But if there's any interest, my laptop is here. Anybody that wants to stay late, I can go till midnight if anybody wants to talk about it. I won't bore you with too much because they did such a nice job with the introduction, but really I think it's important for the audience to know, because here's somebody that's going to talk to you for an hour and a half. You want to be able to see what my background is, what my biases are, figure out what parts of my message might make sense to you, which parts you want to flush away. I basically wear 3 hats. The biggest hat is I'm an educator. I teach, have taught since graduation in dental school, slowly expanding my role. Besides that, I don't necessarily consider myself a type-it-on jockey or somebody that just follows a textbook. I've been in private practice since I graduated, and at this point we have 3 practices, so every day of the week I live it one way or the other. And a day and a half of the week I'm in my own office where I have to make ends meet, make payroll, make production, make a living. So it's not about just here's what the academics say. And then the third thing that probably brings me here to you guys today is my role traveling, speaking, working with industry, being a beta site at the office, trying new materials and what have you. So that specifically a group of us educators banded together. I'm in Catapult. If you guys never have gotten a chance, make sure you get a chance. These are some relatively heavy hitters. If you see a big meeting or a group where there's a Catapult speaker, by all means, they're highly endorsed. I recommend following them, getting onto our site. We do a lot of things, blended learning, digital learning, multiple platforms. So if you have a chance, visit Catapult, and I think that's a good thing. This next slide sometimes is an uncomfortable slide because I am sponsored to some degree. This disclaimer is normal. Speakers always give it. For me, it's never uncomfortable. It's very simple. My line in the sand is if I'm talking to you and I'm going to recommend a product or a technique or a technology, I better believe in it. I better be using it. So my rule is it's either integrated deeply into my office or at school or both, even better. And it's never because of the freebies. I always appreciate the discounts they give their champions or KOLs, but I'm not going to present it to you unless I'm willing to pay for it myself out of my own office overhead. It's on my formulary. So you're not going to see me every other week on stage with a different company. I have my band that I work with. There's not, there's a lot of good companies out there, a lot of good products, but what I'm going to present to you is some of the treatment and education that I believe in, and then ancillarily, here are the products that I use. I like to start with this framework. This is our average. This is what the average overhead in the US practice is, about $390 an hour, and that was before COVID. So we all know what happened. A few years ago, our lives got turned upside down. We were all closed for the better part of 2.5 months. And so this figure, as the forecasters go forward, they start to look backwards, they'll look at it and say, okay, that figure's probably gone up. We all know we pay more for PPE now. Staff costs has gone up. Finding staff is difficult. Materials have gone up. We're in an inflationary period. So chances are it's higher than that, but this is what the baseline is. And that's particularly important to me because remember, I'm in the office a day and a half a week. Now, when I'm not there, I have associates or partners that are there, but my production is my production. And so I have to be efficient and be predictable and hopefully be as productive as possible in that day and a half. So efficiency is incredibly important. And so that'll always be the backdrop. So what we talk about today, speed, efficiency, predictability, outcomes, reducing redos is, I think, is incredibly imperative. And none of that should ever come at the cost of quality. When I was in practice 4 days a week and I only taught 1 day a week, I had a little bit more room for error, right? If I have to redo a couple of impressions, if I have to reseat a crown or start over again, wasn't the end of the world. I'd fit into my schedule. Overhead hasn't changed, it's only skyrocketed. Now I have a day and a half a week to produce it in. So it really had to make me start to think about the way I job cycle, how I make the daily flow more predictable and more efficient. So why this crown and bridge topic I think is important is, first of all, single unit crowns are the staple in practice, right? We can do big glamorous cases, but still single unit restorations are what a lot of us do daily. Aesthetics is more important than ever. It's what drives patients. It's an expectation now. And yet, unlike when I graduated, there's an explosion in modern materials and modern ceramics, and sometimes it seems like there's a new product, a new flavor of the month on the market every day, and so trying to keep abreast of that's important. That's why you guys are here, right? You're attending to learn and stay on the cutting edge. Implants have added a lot of complexity. We're putting more and more ceramics on implants. Understanding how we go through analog, through digital, and what the digital pathway impact is on how our restorations turn out, how the labs manufacture them. And then this is a great thing. We've always been taught to conserve tooth structure, but seemingly it's really kicked into high gear now where there's a huge emphasis on minimally invasive dentistry and tooth preservation. I think that's great for all of us, for the profession, for the patients. We'll spend a little time talking about impressions. Whether you're digital or analog, that's always kind of a challenging aspect, and there's people that always get stressed out with impressions, so it's worth visiting that. And then we'll talk a little bit about delivery of restoration. So there's a million things I have to leave out because in an hour and a half, you're not going to be able to be comprehensive. But I just picked a couple of snippets and we'll talk about it. But here's when I went to school. I didn't have a lot of choices. I graduated in 91, so started in 88 or so. We were doing direct restorations and indirect restorations. So here are my choices. If the patient said, give me something that lasts and is predictable, gold, no pun intended, was the gold standard. And then they said, I care about aesthetics. It's in the front of the mouth. I got to look good. We would still have that metal background, and then we'd stack some porcelain on it. And if I needed to cement it, somebody would teach me how to mix zinc phosphate one drop at a time, because I see a lot of contemporaries here that have done that. And if you mixed it wrong, it would be too stiff or set up or not work. And then, suddenly a glass ionomer cement came along, and great, now we have two choices. And if somebody was having sensitivity, we could put copolite on there, and now we're pretty sure it's carcinogenic and we should have never been using it. But this was it. This was kind of, I'm exaggerating, but there wasn't a lot to keep track of. Nowadays, there's a ton more. If you open up on your supplier catalogs, there's 15 pages worth of adhesives and 10 pages worth of cements. And it can get overwhelming. And so how do we keep track of this? Exactly what you guys are doing, right? Attending CE, reading, talking to colleagues. Here's an interesting little graph that I pulled out of, I think it was in Dentistry Today's? Anyway, Dr. Christensen published it, and it was based on data he got from Glidewell, the biggest commercial lab. In 2007, 65% of the crowns that were being delivered were PFMs. All ceramics were alive and well. They existed. We did a lot of aesthetics then. There was still quite a bit of cast metal, and then some of the others. Just in that 6 years, look what happened. PFMs dropped to below 20%. All ceramics dominated the market. And when we think about this, this was 9 years ago. So if somebody did this study now, or we pulled out that data, I'm going to say that PFMs and metal crowns combined are probably going to be under 5%. The majority of everything is going to be all ceramics. It's where the market's gone. It's where the economics have gone. One big thing that happened here was the subprime crash, where suddenly everything tanked and precious metals went up. So when you were sending impressions to the lab to make a PFM for you, you were getting decent crowns for $150, and then next thing you know, after a year or so, the same crown costs $300, $350 because of the metal weight. And then suddenly Glidewell came out with Bruxer, the first generation of commercially produced zirconia crowns, and you can get them for 99 bucks or 89 bucks, whatever it was. So a lot of people gravitated towards that, and we sat back and said, well, is that really the best thing? This seems strange. It's supposed to be hard. Is it going to break teeth? But $90, $300, you know, what kind of decision were we making? So clearly, PFMs weren't the best choice for this mouth, right? I guess you can argue that they're still here. But what if I told you that this patient had those crowns for about 6 months before they munched them away? And you can look at this. This person's got a lot going on. This is what we define as a hostile environment. It's a hostile oral environment. There's not a lot of decay, but you can see the severe attrition. You can certainly see a significant acid component. There's parafunction for sure. There's a lot going on, and a very well-intentioned person said, hey, I need to put some strong crowns on there. Let me put some PFMs fully stacked with feldspathic porcelain. And the patient proceeded to munch them away. So there are different options on the market, and knowing exactly what to prescribe, when to prescribe it, how to cement versus bond it, how to choose, really is often the difference between long-lasting success and being in limbo and having early failure. I don't think anybody will argue that the benefits with all ceramics, first is obviously the obvious one. It's easier to get a nicer looking result. Doesn't mean you can mail it in. It's got to look good. You got to pick the right shade. You got to imagine what the shine through is, the translucency, but we have a better opportunity to make them look better. We certainly have better biocompatibility. We've all seen folks with angry tissues around the PFMs and that metallurgic response that we see. Depending on the data, you read somewhere between 4-to-1 to 8-to-1 more prevalent in women than men. Women will attest that if they have an earring with a certain metallic content or a ring, they'll get an inflammation or a green band or what have you, but it happens in both sexes. So it's a good thing going there, but one of the big sacrifices we used to make early on was marginal fit. We knew that my definition of all ceramic crown was when I had a PFM and I would cut back the facial metal and put a porcelain butt joint. That margin never looked as good. The gums around it may have been irritated because they were retained plaque, and I could kind of see and I could feel it with an Explorer. That's not all ceramics. The current all ceramics, whether it's a digital pathway, a pressed mechanism, we're getting better and better margins. So there's not really that notion of, hey, I have open margins. Now there are times where they're calculated, especially if you live in the CERAC world. We know that those tolerances with those in-office mills are going to be 100, 150, sometimes 200 microns. Your definitive margin isn't the ceramic always. There's a calculation saying that I'm going to use a strong, insoluble resin, and the resin that I cement it with makes that final seal. So your margin is a hybrid of the ceramic and the well-bonded resin that you put in there. But plenty of these milled zirconia crowns or pressed lithium disilicate crowns will have flawless margins that feel very good, that are undetectable, assuming we give a good impression to the lab or a good scan to the lab. The bonding of ceramics allows us to be able to do more partial veneer and more conservative restorations. It's a little bit more difficult to bond gold crowns. It can be done. It's just more steps. And so back in the day when we did a lot of gold crowns, three-quarter crowns, inlays, onlays, we would have to put all kinds of parallel grooves and retention features. Now the benefit is that we can just take away the disease, take away the areas that are broken. They can be irregular or odd. And as long as we bond them, we can get a lot of service out of them. Patients are happy. I never choose a material because it's a lower charge. But if it's a win-win, if I'm delivering a better restoration and it costs me less, then you can't argue with that. We'll take kind of a case-based approach. We'll look at cases today. We'll answer questions. I love it when people have points and counterpoints, so don't be shy. Speak up. Here are a few things that didn't stand the test of time. People that have been practicing for a while recognize some of these ceramics that have gone extinct. And they've gone extinct for a reason. Manufacturers brought them out. They made a good try. They were there to address some clinical situation or circumstance. And what happened was that we realized they were limiting. Either they weren't strong enough, they were only designed for the front of the mouth, and even then they didn't have good longevity. The old, the feldspathic porcelain jacket crowns, you would prep the tooth down to a toothpick. It would just basically be a pulp horn, a little bit of dentin around it, and they had a half-life of 3 years. So obviously something like that's not going to make it. They were beautiful, but it's not going to make it very long. Some of these other ones, they were either incredibly aggressive, wearing the opposing tooth, or required aggressive preparations, or they would wear or break themselves. And so these are the things that have gone extinct. Here's a list of things that still kind of has stood the test of time. And I would say if I'm lecturing on this in a few years from now, everybody recognizes Empress. It was one of our workhorses. It's what ushered in the cosmetic era, extreme makeover, late 90s, early 2000s. It's pretty much gone by the wayside. It's still worth mentioning because I guarantee you many of you have patients with Empress still on their teeth in your practices. You'll occasionally have to pull one off, maybe match one that's there because the remaining 5 or 6 or 8 are still in function. So it's still worthwhile talking about it, but we've gotten things with better characteristics. And then we've had the zirconia-based ceramics that have a coping. First it started with alumina and zirconia. Then Emax came along, lithium disilicate, took the market by storm, and then zirconia came along. Now really all of these have evolved and they've mixed up the combination technologies to where we're starting to get better granularity between each of these options. We'll talk a little bit about that. So just again, highlights. Empress, 7-year survival rate at 90%. Does that seem good or bad? Yeah, so that's the normal tendency. When I see something, 7 doesn't seem super long. We all know all of our dentistry lasts a lot longer than 7, right? 7 doesn't seem super long, and 90% means 10% failure. That seems not all that great either. Guess what the data says the evidence is on PFM survival rate at 8 years? Right about 87%. So we're very quick to incriminate something new back when Empress came along, but that's about what PFM's lasted. Now the failure is different. An Empress crown that fractured through the middle is a goner. A PFM crown where the porcelain's sheared off, sometimes you try to etch it and add a little bit of composite to it or smooth out or say, it doesn't show it's in the back, just deal with it. The type of failure was different, but they would have issues as well. Suddenly, Ivoclar introduced Emax, lithium disilicate, and the strength jumped up dramatically, about 2.5 times Empress, which means now we can start to migrate it further and further in the back. Empress was kind of reserved for the party zone, maybe first bite of first bicuspid. We would still really say whether you're a clencher or grinder or not, maybe we would recommend the night guard. And now suddenly some of those fears are alleviated and we're starting to be able to put it on molars. Sometimes as far back as second molars. It's what I use for inlays and onlays. Now I make sure I bond them, and there's camps out there that will say you can cement Emax or bond Emax. And some people say, I always do this or I never do this. And I think in dentistry, always and never are words that really don't belong because there's always exceptions. I can tell you my personal preference and how I decide to do it. And I'm going to say I'm going to bond Empress probably, or Emax probably 90% of the time. But there is times, 10%, that I can get away with cementing it. And we can talk about that. Then the Gen 1 zirconias, the 3Ys came along, and suddenly this jumped up from 300 or 400 range to 1,000 megapascals for compressive strength or fractural strength. And this was a game changer. Not only was that the case, but we only needed a millimeter reduction on the occlusal surface with those zirconia crowns. With PFM crowns, if we wanted to have something aesthetic for the patient, and they would always demand, here, we're in the Bay Area, everybody wants everything white. They would demand porcelain occlusals on first and second molars. We'd have to take away 2 millimeters. 3/10 of that was reserved for the metal coping. The remaining balance of it was for the porcelain. They would come back chipped or fractured a year later, 2 years later, unless they just had nothing but mashed potatoes and wore a night guard every night. Things would go wrong. We can talk a little about preparation guidelines and reduction and how that's changed, but that's really critical to the benefits of all the ceramics. If I can put something in there that looks nicer, is more durable, but I can take less tooth away, that's again good for everybody involved. Substrate considerations. No matter what the tooth looked like, if we had a metal coping, we were going to block it out. In fact, our challenge was to put an opaque layer over the metal so that the metal wouldn't shine through. We're trying to make teeth that should be dead and opaque look alive. So the technician would put an opaquer over there, and you try to build your layers of porcelain and try to make this PFM look natural. Try to hide the margins below the gum line or have a disappearing margin. And the really gifted technicians, if you prepped enough away and gave them enough room, could make these PFMs look pretty natural. But most of us can pick out a PFM compared to a natural tooth pretty quickly, right? Becomes harder and harder to do that when we have really exquisite all ceramic work. And we'll talk a little bit about, in fact, I've done a bit of research on this. We'll talk a little bit about bonding and specifically zirconia bonding and when we should, can, or can't bond zirconia. Here's just a couple of video snippets of some of the, oops, went back too far. Some of the weekend warrior courses we do over multiple weeks where we had live patients, doctors would come in, and me and a good friend, Dr. Geisberger, a few of us, would sit with 8 or 10 patients in the clinic, and they'd prep 1 week, big aesthetic cases, and they'd temporize and take impressions. Patients would fly back in town. And I just have, we have like 13 or 14 videos of this. I just have a few of them here. This is kind of a circus, right? Multiple teeth isolated for veneers or crowns. There's a split dam. There's clamps on either side. The palate is sealed with bite registration paste. We're bonding in 2 at a time. These are Empress restorations. And this was hard. It's hard, and we still do this sometimes, but that's what Empress needed. Empress needed reinforcement because it was at best an intermediate strength cement. Unless we bonded it, we couldn't get predictable outcomes. Some of the stronger ceramics now give us the ability to cement. Doesn't mean I always cement them. Many times I still bond them, but it gives us that latitude that we used to have with metal-based dentistry, and so I think that's an advantage as well. So here's a quick decision-making table. And this is as rudimentary as it gets. Most of you are way past this level of sophistication, but it becomes a good little reference if somebody wants to snap a picture. If your biggest goal is aesthetic potential, here's some of the things that can look good. If your biggest goal is blocking out what's there, well, some of these more high translucent ceramics are not going to block it out. If your desire is strength, because a patient has a hostile environment, here's some of the choices. So you'll see where zirconia lands, and this is monolithic zirconia. Bruxer happens to be the trade name that everybody recognizes because they're the biggest lab, Glidewell. I happen to use Microdental, and their house brand is Zeus, but there's something like 70-something manufacturers of zirconia in the world. There's lots of zirconia. They're not all created equal. And now we're on advanced generations of zirconia, 4Y and 5Y. So the big question early on was those early zirconia crowns didn't look so great. Given a patient a choice, a lot of them would say, sure, I'd rather see this than something metallic, something gold or silver or tarnished. But we know they look dead. And early on, it would get a single plus when it came to aesthetic potential. But zirconia has really changed now, too. And so we can get pretty darn nice-looking restorations out of zirconia. Still my go-to for the discerning patient in the front of the mouth is going to be Emax. But I can get pretty nice-looking zirconia restorations as long as I understand what I'm asking for and I choose the right option. A lot of the labs will do this. This is just a marketing slide from Microdental, for example. And next thing you know, some of the mid-translucency zirconias came out, and they were a little bit less dead-looking. And then the high-translucency zirconias came out. And then they would micro-layer the facials. And so if you wanted a stronger zirconia crown in the back, you could get a Gen 3 or a 3Y zirconia and simply cut back the party side, the buccal side. Leave the really robust zirconia on the functional cusps. If this is an upper crown, that's a lingual. You can instruct them to cut back the facial. That's not any different than the 3/4 metal PFMs that we used to do, where we leave the metal on the business side of the tooth and just micro-layer the facial aspect where they smiled if they had a big smile. So this is not a new approach or a novel approach because we did lava crowns. Lava crowns were a zirconia shell that was cut back everywhere, and we would stack it with weaker feldspathic porcelain all around. And somebody said, well, wait a minute. If the zirconia is so good, Why don't we keep it everywhere that matters and just stack the facial or where the aesthetics are important? So this has really gone to new links now. Now the labs will have libraries where you literally can order a mid to high translucency zirconia shell, where you can choose what you need based on the darkness of the stump, what you want to shine through or what you want to hide. And they'll put programs in their mills to cut back 1/4 of a millimeter, 1/2 a millimeter, and allow room for micro stacking on the outside to give it its characteristics, try to make the teeth look really live. But notice, right up to the incisal edge, all the way through the protrusive guidance, is monolithic zirconia. So understanding that and understanding a lab can do that as long as the lab that's able to and has that skill set, and asking for it based on the clinical circumstance is often the difference between having something not break or doing a beautiful case and 9 months later a patient comes in and the corner of a lateral is broken. Doctor, your crown is broken. Notice when you deliver something that looks great, it's always, oh, I love my new crown. But as soon as it breaks, now it's yours again. Doctor, your crown broke. So it's really nice to save those headaches by making evidence-based choices. And especially for me at a day and a half a week, I just don't have the time. I wind up losing productivity if I'm redoing constantly or rebonding or repairing or re-impressing. And so that's what I think I've worked a lot on, is trying to figure out my skills are not any better. In fact, I'm getting older and I'm probably more shaky and my eyes aren't as good. But I've gotten a little bit smarter about the choices I make. And then Ivoclar was not far behind. They came out with, and I hate this, this is zirconia. It has nothing to do with Emax, which people recognize as lithium disilicate. But because Emax had such a home run marketing potential, they called their zirconia, which is now a graded zirconia, where it's a combination of 3Y and 5Y. It's basically a graded block where the incisal can look nice and translucent. The gingival aspect is more opaque, a dent and shade, and it has this gradient technology. They call it Zircad Prime, but they threw Emax in there just to confuse you. But the point is that there's more and more capabilities with all of these ceramics that just allow us to replicate nature more and more. And we want to choose the right one for the given circumstance. So we've come a long ways from here to here. We can do a lot with zirconia. It simplifies your life because now often it's monolithic, strong enough to simply cement. So you want to make the choices. One big thing to understand is always think monolithic for strength, layered for beauty.